and welcome to Pain Points. I'm Dr. Jake Caylor, based out of Austin, Texas. I'm a double board certified interventional pain physician, and today we're going to be talking about the physical examination and the power of touch and what that means, not only for a physician as we're doing the examination and trying to figure out where the pain and dysfunction is coming from, but also for the patient. And so, again, thanks so much for joining me. This is where we're going to explore different topics that are really chosen by you, the viewers. And so, as we go along, I want you to reach out and say, "Hey, Jake, I'd like to talk about this thing. Could you look into this for me?" Because I'm happy to do it, and I'm sure other people have questions and things they want to talk about as well. So we're going to move along here, and this is, as always, this is an interactive session. The goal of this is advocacy, both for ourselves as our family, and education, learning more about medicine. And that's really because I believe you to be powerful, and I believe you to be capable of understanding this information. So join me as we go on this journey and continue on over the next every Thursday from here on out. Today we're talking about the pain puzzle and the physical examination in particular. And so first off, we're going to talk about the importance of touch and why touch became important in medicine and is, in my opinion, still extremely important in the field of medicine. The next thing we're going to talk about is the examination maneuvers, what they mean, why we do them. And I'm going to give you some examples of some different maneuvers we're doing and what we're trying to accomplish with that. We're going to talk about completing the pain puzzle and trying to figure out where the pain and dysfunction are coming from. And then we're going to do our usual anatomy spotlight. And this week, we're going to be talking about the peripheral nerves, specifically nerve blocks being our procedure of choice that we're going to be talking about. And as always, remember, they're not shots. These are targeted injections. And we're going to be trying to figure out why the pain is coming from one particular area. So thanks again for joining me. Always send comments as always. So we're going to move on here. So the importance of touch, the power of touch. The laying of hands has been a therapeutic basis in many cultures and religions for as far back as our memory goes. But its origin in medicine is really Hippocrates. And we talk about not only what touch can help us as the physician identify or the provider, but it also has an importance to the patient. And in my opinion, the doctor-patient relationship, there is something that is very special about touch and the feeling of pain. As I'm manipulating a joint and I can feel the crepitus or that cracking of the joint, that's a very powerful thing, not just for the patient, because I can hear and I can feel their pain as that bone moves, but I also can see the expression of the patient when they recognize that, oh, I see that this thing that they're suffering with. That's a very powerful interaction and experience that we share. Human touch is known to decrease in anxiety. It's known to improve pain, decrease cortisol, that's one of our stress hormones, and also lower the blood pressure. So there's something that just the power of one being touching another that can be very, very impactful. Studies have been done, and they've been done using a special MRI machine to actually look at what happens inside the brain as touch is applied. And this is called functional magnetic resonance imaging. And it's a special radio tracer that's attached to a glucose molecule that looks at uptake. And with this, what we're trying to do is look at different regions of the brain that are activated. And so we know that with doing these specific experience, we can figure out which parts of the brain are active with the physical examination, with touch, with compassion. And so this has become a very valuable tool for us. And this is kind of what it looks like if you've ever seen an MRI machine before. So one of the things that we know is touch is important, and massage therapy is something that is a very interactive touching experience. And with that, you have increases in cerebral blood flow actually across multiple brain regions, specifically to areas that are related to stress and depression. And as we know with pain medicine, there's two huge components to pain, right? We have the somatosensory component, that's what we're feeling. You guys are going to hear me say this over and over again. And the other aspect, which in my opinion is just as important, and that's the emotional affective component of pain, how we integrate and how we respond and deal with pain on a day-to-day basis. And that's what we have in our bucket. Simple hand holding from fMRI data has demonstrated an increase in serotonin. That's one of those. That's one of those biosignals or biochemicals that decreases pain. There's a decrease in substance P, which is a pain-promoting molecule, and there's decreased cortisol, and that means decreased stress and decreased pain from simple hand holding. Touch leads to actual biomechanical change in our brain, and this is something that is really important. That prior to advanced imaging, labs, nerve studies, and all these other things that we used to do in medicine, the physical examination was the most important and powerful tool. And I think it's not just because it helps us figure out what the problem is or where something is coming from, but I think that it's part of the inherent relationship. And when we talk about the patient-doctor relationship, physical examination is part of that, and that's something that you deserve as part of your care. So when we talk about the exam maneuvers, this is more on the other side of it. So the touch itself might be therapeutic, and that's more kind of what the basis of laying of hands and putting hands on the patient kind of means to the patient. But the examination maneuvers, what we do, what we're trying to accomplish with that is a little bit different. And so we're actually taking this very complex biomechanical structure, which is the spine communicating with the pelvic ring, the sacrum, the hips, and we're putting it through different motions to try to figure out, where is the pain coming from? Is this a nerve? Is this a muscle? Is it a nerve that's being pinched and hindering a muscle's ability to contract? Is this a ligament? Is this hypermobility? All of these things are very, very useful. And we have to use all of our senses when we're trying to figure out where the pain and dysfunction is coming from. The physical examination really identifies abnormal sensation, function, movement, sounds, and inherent reflexes. And so that's what we're doing constantly as we push and pull, as we hit you with a reflex hammer. We're trying to figure out, is the circuitry intact? Are the muscles intact, ligaments, tendons, bones, etc.? We utilize a combination of different maneuvers to identify the source of pain and dysfunction. And why is that? Because there's no such thing as a painometer. Just like when we talk about biomechanics and how a pelvic tilt can cause all these other issues, the physical examination is not very specific. It's not like one maneuver is going to say for 100% certainty, this is the cause of your pain. We have to take all of these things together to try to complete that puzzle. And so motor and sensory changes as we're pushing and pulling, asking you to kick out or pull back, trying to test the motor function. We're trying to figure out, is this a nerve cause? Is this a muscle cause of pain or dysfunction? Can the pain be reproduced with certain maneuvers? That can be point to more of a joint or osteoarthritis picture. So all of these things we're doing as we're pushing and pulling, we're trying to elicit, is the strength there? Is this a musculoskeletal problem, etc.? This is one of the things that we're testing every time we do reflexes. Here you see a very complex picture where we have a reflex hammer that's hitting a patellar tendon, and that's activating a stretch receptor that's going back to the spinal cord and then creating a reflex in the anterior horn of the spinal cord. And it seems like all we're doing is hitting you with a reflex hammer. But when I don't see a reflex, that's extremely concerning to me. And if I try to do all my maneuvers, such as having you pull your hands apart, count down from 10, and I still can't do that, that's a neurological deficit. And this has a very real meaning. And if I see a neurological deficit and your MRI is stone cold normal, I need to be asking myself, what am I missing? So this is how the power of the physical examination is not just we're walking through the motions. Every time we're doing it, it's very, very important to figure out what's changed, what's there, what's absent, and where should we be going with your care and treatment. So as an example, I just wanted to point out the sacroiliac joint. This is one of the most complicated joints in the body, but we have all these other maneuvers, and I could sit here and go through all the different 46-point physical examination where we're trying to figure out, what's coming from where and explain it. But in reality, let's just look at the sacroiliac joint. The sacroiliac joint is the joint between the sacrum and the ilium. And in particular, it's important because it transmits the force from the spine into the hips and down the femur. And one of the things that's challenging about it is it moves a little bit, but not too much. In men, it moves about 2.5 degrees. In females, it moves more like 5 degrees, so a little bit more mobile. But the interesting thing is, from a biomechanical perspective, it's extremely challenging to test. And there's no one maneuver that's excellent. Even when we use 3 maneuvers, our sensitivity and specificity, that's a measure of how accurate, if you will, that examination is not that great. And that's oftentimes why we have to pair it with a diagnostic or therapeutic injection to be able to figure out, is this where the pain's coming from? Also, the other thing that's challenging is when we move the sacroiliac joint around, we're also unable to completely isolate any other part of the spine. So while I move the sacroiliac joint around, I might also be moving the lumbar spine. But remember, there's also muscles, ligaments, tendons, nerves, tissues that are on top of that that can be pain generators. And this is the importance of taking and marrying that. The history, that's what you tell us. The physical examination, that's what I'm looking at and doing with my manipulation. And then also the imaging and other studies we have to try to figure out where the pain is coming from. So when I do the sacroiliac joint examination, it's generally a combination of about 6 different maneuvers. And these 6 tests together, I feel like give me a pretty good idea of where the pain's coming from. But it's important to be humble and realize, hey, I'm not capable of isolating this joint. I'm not capable of perfectly pushing or compressing this joint or distracting it. But I am able to try these different maneuvers and hear what my patient's telling me to figure out if this is where it's coming from. The other thing that's challenging with this is if you're in a pain crisis, so your pain is so severe that you can't move, it's really challenging to do these examinations because we don't want to cause pain, or you might even be unable to tolerate it. So that's another thing that we have to think about with the physical examination. So for the SI joint, I use 6 tests. One is Faber. That's actually where I'm taking the leg, pulling it out, and pushing the pelvis together. Gainsland's test, which is where I'm hanging the leg off and I'm pulling. And then the Fortin finger, I use the thigh thrust test, the SI joint compression test, and Newman's maneuver. All of these maneuvers together give me a pretty good idea. But to be completely honest, it's difficult to know clearly whether this is the cause of the pain unless we're also doing an injection to try to target and put some numbing medicine in that joint. So all of these things are important when we talk about our arsenal of both diagnostic and therapeutic approaches to the pain. One of the other reasons I think it's so challenging let's just look at these common areas that the sacroiliac joint will refer to. When we talk about which aspect of the sacroiliac joint is painful, these are all the different pain patterns you can have. You can have pain that's in the pelvis. You can have pain that goes down the outside of the leg. You can have pain that goes all the way to the foot. This is the importance of taking everything together because there's no cookie cutter saying if you have SI joint pain, it'll hurt here. You can have pain even into the groin. So all of these things that we look at, we need to say, okay, here's the information that I have. This is the other data that I have. Here's my physical examination. And then out of that creates the differential diagnosis. So when we talk about the pain puzzle, you really have no one thing that says this must be where the pain is coming from. And this is what this first kind of 6-course introductory slides with, or the 6-part course that we've been working through, Pain 101 for the last 6 weeks, has been really, really important. Is the pain puzzle is challenging. It's a complicated picture of biomechanics, and in order to identify the primary generator often of pain, we oftentimes have to peel away all these secondary pain generators, evaluate the biomechanics, work closely with our colleagues, whether those are physical therapists, whether those are surgeons, whether those are primary care physicians, to be able to figure out where is the pain coming from and what are our treatment options for it. So now we're going to kind of move along and away from the physical examination. But I think this is, just to end on this, it's really, really important to do a physical examination. And yeah, there are times where we can't complete the physical examination to the extent that I would like, but that might be because we have more pressing matters to discuss. And so I just want to end this by saying the physical examination is a key aspect. If you've had your pain change and you're trying to figure out where it's coming from, you should insist on a physical examination. And if you haven't had one, it's okay to say, hey, doctor, do you mind pushing on this? Do you mind examining this for me? Because that's one of the services that is both valuable to the patient as well as the physician. So now we're going to talk about the peripheral nervous system. In addition to the cranial nerves are the nerves that come directly from the brain. There are 31 paired spinal nerves, and there are hundreds of nerves that go throughout the entire body. After the spinal nerves exit from the spinal cord, they send other communication to nerves that are around them. The nerves to the arms, the legs, the pelvis, the organs, they have these little exchanges where it's what I call the spider web. So it's not in the spinal cord, it's outside, and it forms a spider web of nerves where they're sending fibers in other areas to get to the final target. But we call this a plexus. So if you've heard of lumbosacral plexopathy or cervical plexopathy, these are all different issues of nerves, not in the spinal cord or brain, but after they have exited. And they can cause pain. This is one example of the lumbosacral plexus. You can see all these different communications. And so one of the things that's challenging for us is it's important to know that these nerves here, these exist both on top of muscle, but also piercing through muscle belly. So when we're trying to diagnose where pain is coming from, we don't have to just look at the levels, the L1, the L2, my L5 hurts. No, your L5 goes to multiple different areas. So we have to be able to take all of this together to figure out where the pain is coming from. Because you can have pain that is from an L5, but you might have pain that is from the L5 just out after it's exited, and when it's communicated a little bit with the L4. And then maybe there's a little communication with the S1 as well. And now all of a sudden we have a picture that resembles sciatica from the spinal cord, but is in fact sciatica peripherally. That's an example of piriformis syndrome, if you've ever heard of it. So why do we do nerve blocks then? That's a really great question. Peripheral nerves can be damaged. They can be trapped through multiple different processes. They can be irritated. When a single nerve is a problem or a pain is in one nerve territory, we can generally do a nerve block. If you have nerve pain all over, obviously we can't do an all over nerve block. But inflammation occurs with the spinal cord with repetitive nerve signaling. So as that spinal cord or as that nerve is sending pain signal over and over again, it does create inflammation within the spinal cord. It's using up that energy with that constant signaling, leading to that inflammation. And this can come from continued tissue damage, such as arthritis. So chronic knee pain, sending repetitive signals to the spinal cord for the knee hurting. Mechanically damaged pinched nerves that have been, or nerves that have been cut. This is something that can cause pain, like after hernia surgery, constantly sending nerve signals to the spinal cord that also can create inflammation. Biomechanically or biochemically injured nerves, such as diabetes, so having very high blood sugar, or alcohol, these can lead to issues with nerves being damaged. And so all of these together create situations where there is inflammation in the spinal cord, and that leads to more pain signaling and a dysfunction in the regulatory mechanisms of how we experience pain. So what do we do with a nerve block? This is an example of an ultrasound guided sciatic nerve block. And you can see here, there's the sciatic nerve, and we can actually take a needle, there's the needle tip and the needle going, and we can place medicine around the nerve. So why do we do this? A nerve block is both diagnostic and therapeutic. Imaging guidance must be used for certain nerves to be able to get that needle close to the nerve. Now, the reason I say certain nerves is there are nerves that we can't see. And if there's no way to see it, then we can't use imaging guidance, and we have to use an anatomical correlation. But even in those cases, we tend to use something like a fluoroscopy machine to guide the needle to where we want. When we inject medicine, we inject local anesthetic, which is a numbing agent, and a small dose of preservative-free saline or a steroid. And the goal of this here is to stop the nerve from sending a signal. And it's like when you call your computer repairman because the computer's not working, or you call technical support. What are we really doing with that? What's the first thing that they ask you to do? Have you tried turning it off and turning it back on? And that's really what we're trying to do here. We're trying to turn off that nerve signal. And if we numb up that nerve and your pain goes away, okay, we've identified something. If the pain doesn't go away, then okay, we've learned something there too. Both very, very helpful. So the first thing that we're going to do is turn that nerve off. And then the second thing that we're doing is allowing it to wake up in a nice steroid anti-inflammatory bath to help calm down that chronic pain signaling. Additionally, the nerve actually takes up that steroid and brings it back to that inflamed spinal cord. And that's why we get long-term pain relief with a simple nerve block. If we just put local anesthetic in there, that might help too. Calm the nerve down enough for 12 hours, maybe that will help. But if we put that little bit of steroid in there, that steroid goes back to the spinal cord and decreases that core inflammation that can be kind of helping propagate those pain signals. And that's what I was saying before. Turn it off and let it wake up in an anti-inflammatory bath. And this is really to show you that that nerve cell body is really back in the spinal cord, and these processes are long. So there's one cell that extends from the spinal cord all the way to your tip of your finger. And so if you put medicine at the tip of that finger, you're able to have it bring it back to the spinal cord. And that's in essence what we're doing. As always, I have time for question and answer here. And thank you so much for watching this week. And then the last thing I'd say is leave a comment on our Facebook. I love being able to interact with you there, and let us know what you want to discuss next. Next week, my plan is to discuss sciatica and talking about low back pain that radiates to the leg, because that's a very common thing, but we have lots of things to talk about. If there's something you want to talk about or learn more about, let me know. I'll build it for you, okay? I'll take questions. Otherwise, thank you guys so much for joining, and I look forward to seeing you next week.